We have a flexor tendon, and one of the most important things about a flexor tendon is that you don't want them to go all the way straight. I mean, it's not gonna, if they're sitting like this, it's fine. But what you want to do is you want to teach them to just be in a very relaxed position, right? And you want them to be in a very relaxed position because when they come out of their splint, you don't want them trying to move and trying to hold and trying to open, right? Especially if it's very new, okay? So one of the most important things is when you take off the bulky dressing, you just tell them, just go ahead and relax your hand. Now, if you take a look at the hand, there's a natural attitude to the hand. If you let the wrist go down into flexion, the fingers automatically extend, right? If you relax the fingers and we're gonna move the wrist into extension, the fingers automatically close. That's just the normal tenodesis attitude of the hand, right? And we're going to use that to our advantage. So we're going to put the wrist into in a relaxed position while we get everything ready. So this is a laceration of all three fingers, both the profundus and the superficialis, along with some digital nerves. Now, I happen to have talked to the doctor. He said the repair is very strong, and then he did some neural tubes around the digital nerves, and so we don't have to be careful with them. The reason why, the structures in the fingers are so close that when you cut the flexor tendon, it's very easy to cut the digital nerves. And in years past, when you do a digital nerve repair, you would follow the same flexor tendon protocol, like a modified Duran with the wrist in 20 degrees, the MPs in flexion, but the IPs, because of the digital nerve repair, you would keep the PIPs at 30 degrees flexion. 20 to 30 degrees flexion, but if you keep in flexion, guess what's going to happen? You're going to have a really hard time going into extension. So anyway, he told me that they were wrapped around, there's neural tubes and stuff like that. The repair is strong, that we can get started really early with early motion and all that good stuff. Great, we can be a little bit more aggressive, which means I want to make sure that the PIPs are in an extended position, in zero if possible. So after we make the splint and everything, one of the most important things is to initially start to educate them on what they're able to do at home, right? You want them to do everything inside of the splint. Now, I'm gonna do things with him outside of the splint because I'm gonna get a better handle without the splint. But when you teach them, you're gonna teach them like, oh, I'm doing X, Y, and Z, and when I want you to do it, I want you to do it at home inside that splint, all right? So I normally don't keep the wrist in 20 degrees. When I can, especially when I know the surgeon and I can talk to him, and I'll put that wrist in zero, right? Because it's just gonna be less work later on, especially if they're already telling me, well, I did a strong repair, the integrity of the tendon looks good and stuff like that, then I'm gonna start at 20. I'm gonna start at 0 versus 20 degrees. That makes a big difference already, because then when you take them out, you have to work on like wrist and stuff like that. So I start at 0. MPs are in a safe position. Safe position means 60 to 70 degrees, right? So if I'm working with someone, I'm gonna flex their DIP. We're gonna go down as much as possible. I'm gonna go down as much as possible, right? Now, obviously I'm holding right here and the guy's got incisions all here. So it's just whatever you can tolerate. So my pressure is now gonna be less, right? You feel that? I'm gonna do DIP flexion extension, DIP flexion extension, and you gotta be able to extend to 0. If you've got them in a relatively safe position of wrist to 0, you can even put them in a little bit of flexion of your word, but 0 is fine because the MPs are completely flexed. So you wanna go into extension just as much as you go into flexion. Extension and flexion. And then you're gonna go PIP, flexion, extension, flexion, extension. The tension you feel because of your finger placement, you're gonna feel that on the tendon. You're gonna know how much to pull. It's gonna be like a pulling, right? A firm resistance that you can go up against. Moderate resistance, sorry. Firm, you can leave alone, right? First day, talking on first day here. We're gonna take it nice and easy. It's DIP, PIP, and then you want composite. All the way straight, curl it in, composite. This is all passive range of motion. So if you're able to touch that palm, you're in a great position. You go to 0. Now he's in a great position because he can touch his palm. And he can go almost to 0. He's probably at minus 10 degrees, right? But that's all right. We'll be able to get that. So you go individual, each finger, all the way down, and then up. So each finger, DIP, PIP, and then together composite, and then all the way out. Composite and all the way out. All right, so that's what you're doing. It's real nice and gentle. Obviously, you're gonna feel some resistance because they're gonna be tight. He's got a certain moderate amount of swelling, so he's gonna feel it. As soon as you feel them pull, you have to tell them, don't pull. You might even put them into, if they're painful and they start pulling, you can put them into some wrist flexion just to be on the safe side. Just tell them don't pull, right? If anything, go ahead and open your fingers. There you go. If they want a little bit of movement, you can just put the wrist into some flexion, open your fingers, and then you're safe, right? Because you're in a safe wrist position, okay? You can do one finger at a time, and then you can go just to check it a little bit. So the way I check the wrist is I'll bring the wrist into some extension, I'll flex the fingers, and I'll pull the wrist back a little bit. Because I just want to feel how much give is there in the wrist. Everything looks good. And one way, which is very important, I always recommend test your flexor tendon integrity on the first day. I've had patients before where they come in with a ruptured tendon already. And everyone likes to blame the therapist. Ruptured tendon, right? It's the therapist's fault. There's another theory behind that. But you just don't know. I had somebody who came in and she was fighting her post-dressing. And we knew it and she knew it, but she was starting to get some dementia. And under anesthesia, it brings out the forgetfulness, and she was fighting her post-op stuff. So when she came in to therapy, her post-op dressing was like half off. She had like been clawing at it. It was like she was holding almost unraveled. And so you always want to check the integrity of that tendon. You should be able to feel it pull, right? Best way to check it is you're just going to keep the wrist into a little bit of flexion. You're going to keep the MPs in flexion so you know that you're in a safe position, right? You're going to put your finger pretty much down here, because if you're testing for the profundus, you should feel a little glide, right? And what you're going to say is, okay, so what I'm going to do is I'm going to test how good your tendons feel. Now what I want you to do is I just want you to move just a little bit. Just pull very lightly, just a little bit. There you go, that's it. Perfect, feels good. So you want them to pull ever so slightly, right? All you're looking for is a little wiggle and for you to feel on the tips of your finger that tendon. So now what I'm gonna do is I'm just gonna test the next one. So just gently pull a little bit. There you go, boom, done. Don't pull anymore, relax, right? So they like so anxious, they wanna move it, and all you wanna feel for is that glide. If you feel for that glide, you know that that tendon is intact. If they don't move, you still can feel that glide because it's trying to pull, but you already have in your mind an idea that, oops, that tendon is gonna start to adhere down really fast, right? So he's very nice, loose and limber. I felt that tendon glide really nicely. And if anything, we just wanna make sure that he doesn't move too fast. Right? I always tell them, if you go too fast, right? If you try to move your hand and you're making a fist and you're doing all this, trying to use your hand, if you rupture a tendon repair, you need 2 more surgeries. And if you don't do the exercises I need you to do, and you're not doing them, and you're not moving that tendon, and you get stuck, you're gonna need 1 more surgery, right? So we're trying to avoid multiple surgeries here. So I would check for each tendon that was repaired, because you wanna document that you felt the integrity of that tendon and that you had some glide, you know, and that if something were to happen in between, you can say on the date of eval, you know, that it was intact. Right? And the direction is pretty much, you know, not to use the hand, not to go all the way back, not to squeeze. You want to just only do passive range of motion, and then we can get into all the technicalities of the protocol, like at week 3, at week 4, at week 5, and actually what I do a little bit beforehand, because when I know a repair is strong, I'm confident to move just a little bit faster for better results. Hey therapy friends, it's Huang here. Thanks again for watching my video. And if you like videos like this that can help you just crush it in the hand therapy world as an occupational therapist, then hit the subscribe button and enjoy the video. Thanks again for watching.